welcome all my colleagues from Jayadev Institute of Cardiology for this international speaker program. Professor Dr. Piotr Poliborski is a pioneer in the field of heart failure. He is director of the Institute of Heart Diseases from Wroclaw Medical University, Wroclaw, Poland. He is actually a member of the executive committee of Victoria Trial. His main research focuses on heart failure, and he has co-authored more than 900 peer-reviewed papers with citations of more than 150,000 citations. He has been included in the Thomas Reuters ranking of the world's most influential scientific minds between 2016 and 2021. And he has served as a member of the Board of Heart Failure Association of the European Society of Cardiology between 2004 to 2019. And he served as the President of Heart Failure Association between 2010 and 12. He is former President of Polish Cardiac Society between 2017 and 19. And he was the chair of the 2016 ESA Heart Failure Calendar. So, a renowned figure in the field of heart failure. We welcome you, Professor Dr. Piotr Poliborski, for this speaker program.
Okay. Thank you very much. And I'm completely open. Okay, so it would be my great honor because just last week I was in India. A great meetings over the 2 days only with several specialists. A lot of so this is why I'm staying at home, recovering much better now. So once again, my deep appreciation and apologies that I'm not able to be there in person, which I would love to be.
Thank you and welcome, Dr. Piotr Poliborski. And sir, is it okay if I share the control to you for the slides? Hello?
I think, Professor, you're on mute.
Okay, shall I now? Okay.
I have given the control to you, sir. You can have the control right now.
Yes, perhaps this is the part of my presentation. So I'm sure that we will be debating worsening heart failure, but in the context of the Victoria trial, and I would be more than happy to give you the short summary of the Victoria trial results in order to the readmission rate, the rate of worsening heart failure again and again is actually either stable like in Asia or even increasing like in North America or Europe. I can tell you that before we discussed this with colleagues in India 2 days ago, several years ago, the main admission, I'm responsible of an institute. We have 8-10 admissions, cardiology admissions every day to at least half, if sometimes more, is due to heart failure worsening, and these patients are admitted. So this is really a growing incidence. I'm sure that you are very well of this. This is a slide I'm showing quite often because we all somehow intuitively take for granted that if we have this quadruple therapy, meaning all these drugs, 4 drugs, harmony, beta blocker, MRA, and dapagliflozin, because this is from DAPA, but the same story applies to EMPA, virtually the residual risk is negligible, is minimal. This is absolutely not true. Only this slide shows that despite optimal medical care, with all 4 magnificent 4 drugs recommended in the guidelines, devices, the risk of residual risk of decompensation of that only within 20 months is really huge. Is more than 10%. 1 in 7 patients will be readmitted or die in such a precisely controlled clinical study. You know that in epidemiology We have the same story in India as I had, even sometimes bigger. And I must say that in India, I heard you have even having prevalence of 2%, 2 to 2.5%, you end up with 30, 40 million people having heart failure. I am particularly proud of this slide because this slide is actually a summary of our understanding of worsening heart failure. We didn't use this word. We used the word acute heart failure when I chaired the guidelines 6 years ago. It was 2016. But even in 2016, we didn't use the word worsening. We somehow extrapolate worsening equal acute. Most patients treated in hospital at that time. However, even at that time, we pointed out very, very clearly that before discharge and just after discharge, in this peri-discharge period, what really matters is to remember to initiate and up-titrate disease-modifying pharmacological therapy, which would be absolutely fundamental, absolutely crucial. And this period of worsening and post-discharge, early couple of weeks time would be ideal to plan the treatment. And as we said, make sure that we schedule the subsequent visit, make sure that the patient and his family will know who will see the patient and when. And I can very well remember that we were heavily criticized by saying something which is stupid perhaps and obvious, who will see the patient and when. But I must tell you, in my country, in many European countries, in America, it's very rare that this hundreds, thousands of patients leaving the hospital will have, and their families, will have a very clear follow-up program, would know who will see them and when. So this is our challenge. I love this figure, which we very often refer to, developed by Lemuel Stevenson many years ago. She pointed out that after the worsening event happening, so either hospitalized or treated ambulatory, the patient reaches the most vulnerable phase of the disease. This transition phase from worsening period, decompensation, to more stable ambulatory care is always linked with a very, very high risk, the most vulnerable phase of the disease. And I think this is why we need to understand that our approach to this worsening acute heart failure event should be highly different. This is the lesson learned from the past failures. Many years ago, many of us took for granted that worsening event, acute decompensation, is only about very acute early phase. So in clinical trials, we did our best to restrict our interest to the early phase. We learned this from acute coronary syndrome. We took for granted the concept, the sooner the better. Opening the artery, infarct artery, would apply to acute heart failure, worsening heart failure event, which was wrong, which was entirely inappropriate. Now we see, and Victoria is the best example here, together with some other trials, that this peri-discharge phase initiated early and then followed by during several months, it's a key and fundamental. We are calling this peri-discharge phase of heart failure worsening. And Victoria fits here very well, together with some other studies which demonstrated benefit of several approaches. So ionia SGLT2 inhibitors, and finally our IV iron therapy to the HF slide. This slide shows you that, in fact, this worsening heart failure population, which we included in Victoria, was different than patients who were previously studied in ambulatory setting. In this slide, I made sure that we compare the event rate. And in this aspect, I consider heart failure hospitalization and cardiovascular death. And if you look carefully, you will see that this mortality and heart failure hospitalization or risk of another decompensation worsening in the period when we recruited patients for Victoria is much, much higher than in the stable phase. Don't get me wrong, I'm saying stable. There's nothing like stable. I'm saying ambulatory setting. The event rate was 3 to 4 times higher. It was a little bit lower than in those admitted to the hospital, but still high enough. And here is the summary. First sort of introduction of the Victoria, showing you that 100% of these patients were recruited indeed in this post decompensation state, as you see here, with very, very high events. Many of whom tended to have a low eGFR, many of whom tended to be hospitalized, not treated ambulatory, and I will get back to this later. So this is now the concept of the whole study, the design, the concept which was behind. I can very well remember and recall that we debated what would be the optimal population to initially start, because the next studies with Sequat will come, and I will tell you about Victor program in a second, that just mentioned. But we studied in Victoria the growing population for whom we don't have a specific. This element, this phase of natural heart failure history was never prospectively evaluated. So worsening heart failure, meaning distant heart failure decompensation, elevated natriuretic peptides in patients who are symptomatic, who tended to have a chronic ambulatory heart failure with ejection fraction below 45% on available therapies. For your perusal, we wanted to make sure that they were stable. In other words, with systolic blood pressure of 100 and above, without IV treatments, including IV diuretics. There was no random phase to the study. And here we see the design. Very simple, very straightforward design, I would say. We wanted patients to be randomized 1-to-1 into either placebo or vericiguat up-titrated from 2.5 once daily to 10 milligram once daily during this first 4-week period. So 2 weeks, 2.5, if the clinical status allows, then we went for 5 and another 2 weeks step. Finally, we ended up with nearly 90% patients treated with optimal 10 milligram dose of vericiguat. As you know very well, the primary endpoint was the composition of cardiovascular death and heart failure hospitalization. This is quite an important element of the whole discussion, because we wanted to be sure that we actually somehow target a novel, not already target pathophysiological pathway here. As you know very well, I should start the other way around. We believe that we understand more or less, okay, the pathophysiology underlying deterioration in the context of neuroendocrine sympathetic nervous system, perhaps also what we target using ARNI. But in fact, I remain skeptical here. Whatever we say, we should summarize this way. Several potential pathways with existing therapies are targeted, but we were very well aware that the pathway of nitric oxide, soluble guanylate cyclase, cyclic and down road cascade of cyclic GMP being activated or inappropriately activated, was not targeted, although there were several studies showing that this particular pathway may well be also very important for heart failure progression, not only in animal studies but also in human studies. This is the slide that Paul Armstrong and author of this paper as well proposed to somehow explain what is this novel signaling about or targeting with very insufficient cyclic GC, cyclic GNP, soluble GC, sorry, cyclic GNP signaling. As you know, as you see here, due to several different underlying pathophysiological mechanisms in heart failure, mainly oxidative stress, inflammation, but also neuroendocrine activation, this cyclic GNP signaling with the cascade down road with activation of several other enzymes and process in the mainly we thought several years ago endothelium, but now we are sure that it is about myocardium and some other tissues as well, is impaired. This slide shows you that vericiguat carries two modes of action. One is independent of nitric oxide by direct stimulation of soluble GC. The second is just enhancement of sensitivity of soluble GC to endogenous nitric oxide, with some other evidence existing before the trial that there are some potential beneficial effect of targeting this mechanism. We needed to always need to verify the hypothesis in large clinical trials, and this is our aim for Victoria. As I mentioned, here is the baseline characteristic. Very briefly, as you see here, around 60% of patients on triple therapy. Sorry to tell you at that stage we didn't have SGLT2 inhibitors, and this is why any kind of a consideration what about vericiguat being added to this magnetic effort is not we can't really answer this based on Victoria. Then, as you know, as you can see here, relatively many patients with very low GFR, between 15 to 30, more than 500 patients. I will show you the data in a second. Vast majority being hospitalized within this last 3 months. So this most vulnerable phase after hospital discharge. Pretty, I would say clinically important, not previously studied, prospectively selected patients during the natural course of heart failure, this worsening heart failure event. Here is the primary endpoint, and I would like to draw your attention that only within median time of the study, 10 months, we achieved significant reduction of the combined endpoint of cardiovascular death or heart failure hospitalization. In other words, vericiguat added to optimal medical therapy decreased the risk by 10%, with annual number to treat of only 24 and absolute risk reduction of 4.2 events per 100 patients. Yeah, you would challenge me by asking, is this really reasonable? Is a huge number? Is this clinically relevant number, or is that a negligible number? I will show you in a second comparison between Victoria and other clinical trials over the last couple of years. It's not historical knowledge, but comparison between Victoria and other recent clinical trials. Here are the secondary outcomes. And what I would like to reiterate is that there were numerically, as you see here, less deaths, both cardiovascular and all-cause mortality, which did not reach the statistical significance. But what I would like to draw your attention is that the risk of heart failure hospitalization, the risk of recurrent heart failure events, recurrent heart failure decompensation, as you can see, so heart failure hospitalization burden, I would call you, vericiguat added to the therapy, to the optimal medical therapy, increases risk significantly. This is the slide I have already mentioned, a comparison between Victoria versus the other clinical trials in the context of absolute risk reduction in Victoria 4.2, Galactic around 2, Emperor and DAPA-HF in the range 2 to 5, and Paradigm in the range of 2.7. So the absolute risk reduction is pretty substantial. What about safety? I'm sure that you know this very well. I'm just going to briefly remind you, and I'm sure that you will challenge me with numerous clinical questions. I just want to make sure that we all see this in the perspective of the data from Victoria, because Victoria is the only study for which we as I'm saying, in this population. So the number of adverse and serious adverse events comparable between placebo and vericiguat, what really matters, and what was a certain concern for us before we started the trial, was potential risk of symptomatic hypotension, syncope, or hypotensive events, which may, particularly in this population, as you see here, numerically there is no difference. Syncope as such was very rare, in the range of 3 to 4%. In the context of symptomatic hypotension, there were no differences, 8 versus 9%. And as you heard, vast majority of patients were treated with 10 milligrams of vericiguat. Once we completed the study 2 years ago, if I remember correctly, around 30-something papers were already published on different aspects. Obviously, we don't have time to discuss them. I will be more than happy to address questions afterwards. Just I would like to draw your attention: renal function, optimal medical treatment, plus vericiguat, blood pressure, and recurrent events. This is the analysis across all spectrum of eGFR. As you know very well, no difference, no heterogeneity, very homogeneous results. Here we have a summary of adverse events in this very low eGFR group. Obviously, these patients tended to have more events than those with reserved ejection fraction. But again, as you look clearly, there is no difference in adverse events between these two groups. Another story, the story of the trajectory of sodium and potassium level, no difference between vericiguat and placebo. What about ARNI, so optimal medical use in the medical treatment in the context of ARNI use? We were pretty concerned with it, because remember that once we planned this study, we tended to have some evidence from the past on potential hemodynamic deterioration with vericiguat, but here it was not the case. Even in those being treated with ARNI, the likelihood of adverse events was not increased. In patients receiving vericiguat, as you see here, the benefits were equal in those, there was no difference between those being treated or not treated in ARNI. In other words, ARNI treatment does not lessen, does not decrease the benefit related to vericiguat. So vericiguat was effective across all treatment strategies used in this Victoria trial. Here we have a little bit different approach, showing that also if patients were treated in hospital or were ambulatory treated in the context of worsening heart failure, sent home, there was no heterogeneity, the treatment were equally well. Here we have something which is, in my humble opinion, pretty important, because it shows us that not only first, but also repeated heart failure worsening events, the risk was decreased across the whole spectrum of patients. So as you see, it was not only first, but also subsequent hospital admissions. So heart failure hospitalization burden in general was decreased. Here we have again some more data on systolic blood pressure. If you look carefully across the whole duration of the study, comparing systolic blood pressure trajectory, make it this way, there was no substantial difference between vericiguat versus placebo. In the entire population, it was in the range of 1 to 2 meters. However, what we were particularly interested, and this is the paper published by Carol Lam in Japan, showing that in particularly vulnerable populations to develop symptomatic hypertension, so patients over 75 years, patients with initial blood pressure in the lowish, between below 110, and those with concomitant use of ARNI, there was no risk of increased hypotensive events. That was pretty solid and important information. So this is the summary. Vericiguat added to guideline-directed medical therapy were tolerated in these patients with worsening events. Here is my humble suggestion, our humble suggestion about where does vericiguat fit in the context of heart failure trajectory, optimal therapy. Some of these patients tend to worsen, and this is the best timing to consider vericiguat being added in this pretty common, as we already have, clinical scenario. This is not, don't get me wrong, this is absolutely not at your level of expertise by any chance. I don't even feel offended by me showing this slide. This is the slide we developed for a better communication with our colleagues. Because I'm sure the same in your country, in Europe, vast majority of patients afterwards are treated by general practitioners, by insurance. Also, very few patients are treated by very highly special teams during the compensation, during worsening. So we prepared kind of a strategy how to communicate, how to make awareness of this towards our colleagues, general practitioners, specialists in internal medicine. So we pointed out that 3 scenarios. One is in hospital prior to discharge, like in this gentleman. The second is the first follow-up visit, after first or second, after failure hospitalization, since early post worsening heart failure event, and finally for those who tended to have ambulatory optimization due to worsening heart failure event. That would be the end of my presentation, and I would love to take questions. I'm sure that you have your own experience, because as I had already started using this. In Europe, this is still not very common practice. Also in America, so I'm sure that soon you will have much more practical evidence. That would be the end, so please feel free to challenge me with questions, and I hope that I can cover them and answer.
Thank you, Professor, for the enlightening lecture. At the outset, what is the mechanism, behind the worsening heart failure? Because there are a lot of students here for the benefit of them. What are the baseline mechanisms which worsens the heart failure despite guideline-mediated therapy? The residual risk which we saw in various trials. Why does that happen?
Well, that's a great question.
We have lost you, Professor.
I should say with a clear answer that in around 40 to 45%, we are not able to identify the cause leading to decompensation. In other 60%, we identify causes which are potentially target for specific therapies. We should start with acute coronary syndrome. And this is in our guidelines. We develop an acronym, I get back to it. So, acute coronary syndrome, hypertension, hypertensive crisis. Then we have arrhythmia. Arrhythmia in the most common is obviously fast atrial fibrillation. Then we have mechanical causes. Mechanical causes, which is rare, but very common. So we identify this as a potential cause which should be specifically targeted. The next one is obviously pulmonary. So we have this CHAMP acronym. CHAMP has 5 cases leading to decompensation. We can identify and treat. The current 2016. In 2021, they added on the top of it another 2, so it was CHAMP plus IT. I is infection, very common cause of deterioration, and often related to outcome, and T means for tampon. We are all very well, and this of 7 underlying causes we can identify and treat separately. But there is also very common cause. It's not easy to be changed and to be targeted, is compliance in a general sense. So it is one of the most common particularly in the area where I live, in Poland, in Europe, I'm sure the same in your country. The patient tend to forget how to use the therapy. Although we believe that they are an optimal medical therapy, compliance or lack of compliance is an issue. Lack of compliance not only to the therapy, but also lack of compliance to general rules. We are trying to persuade our patients to follow. Like once I'm talking to patients at the ward and in the ambulatory care, very few of them, take into consideration regular weight control. Most vast majority of them, they tend to weigh themselves not every day because they believe that it's only for kind of a diet. This is not for a diet which tends to teach them and the families. This is about fluid. So 3-4 days and an increase in the weight of 1.5 to 2 kilograms. So we act immediately. This is very rare. Another story is about diet, about regular exercise, about salt. Don't get me wrong, I'm not proposing low salt because there are no data, but I'm telling you about moderate. I'm sure that you all know that, but because you asked me this question, due to students sitting there, I would be more than happy to elaborate on it. But this CHAMP IT acronym plus non-compliance, that would be my answer.
Yeah, coming to the present molecule, Siva, how do you place this molecule and what stage should we introduce this molecule and
I would, to be honest with you, I would place it at that moment as a molecule which carries a unique capacity to target a not targeted yet mechanism of heart failure progression. If you ask me whether this is the major story, I can only tell you I can't answer this question, because if I ask you what about beta blockers, how they work, we can debate for an hour. If I ask what about this GLP-2 inhibitors, how they work, you can say I don't care, I just can say that they work and I don't care how they work, So, but definitely there is something which is additional into the pathophysiology of heart failure, which we can target with this molecule. At that moment, we can have evidence that a population of worsening heart failure is a population for this molecule. We can't say more about more stable patients, And this is already because I alluded to the concept that perhaps the earlier we start with this molecule, the earlier we start with targeting this pathway with this molecule, or another pathway with this molecule, which may well be the case, the better. And this is the concept which is now prospectively evaluated in another trial, which is called VICTOR. The VICTOR trial is actually just about to be in a, well, started a couple of months ago. We have pretty many patients already recruited. I remember that we had the meeting at the European Society of Cardiology in Barcelona. We see the very good recruitment due to commitment of several countries on the board. And this is the study not of this worsening heart failure population, but the study of patients who didn't have worsening. So they are in this area, don't get me wrong, more stable, in a sense, more ambulatory phase or natural course of disease. So this is my answer. If you are not happy, please challenge me. I would be more than happy to answer.
Professor, if it is, what I wanted was, when you say worsening heart failure, is it falling ejection fraction, or is it more symptoms due to volume reduction which will benefit? Which group will benefit the most? Means now we have the diabetic on board in the given population, beta blocker, army and SGH2. Okay, in this population, yeah. Now, worsening heart failure means is retaining volume is.
I understand your question.
Is it that true?
Yes, I can easily answer this. Yes, I tell you one vast majority. If you take all patients admitted to the hospital due to or treated ambulatory due to worsening heart failure, around 90% of them, 90% of them, if not more, are not treated because they tended to have a low blood pressure, hypotension, deterioration in hemodynamics. But 90% of them, they tend to have a wet profile. Wet meaning volume overload. Wet meaning congestion. This is the major part of the population tends to see. In the Velsiqua Victoria trial, we did not include patients who tended to dramatically deteriorate with low blood pressure, needed to have a support with inotropes or some other devices. We wanted this vast majority of these patients then to compensate because they had a gradual or fast volume overload. We can discuss about two different mechanisms of volume overload. I have a very strong opinion that one is volume shift, one is volume accumulation. But anyway, so at the end of the day, we have a picture of a patient who is clinically wet, most of whom are wet congested, most of whom are wet and warm, in other words, wet and systolic blood pressure over 100, 110. And this is the idea of, we have a patient either ready to go home or a couple of weeks after this worsening event, after the compensation. This is the best, despite therapy, this is the best period to think of Velsiqua and initiate Velsiqua.
Thank you, sir, for your excellent overview of this particular new drug. And yes, we just wanted to know, is it going to be the fifth pillar of heart failure management? Because we have already 4 pillars. Because FDA also has approved this project. FDA also has approved this project, and in particular this particular drug. So it's going to be the fifth pillar because we have usual other 4, including SGLT2.
Point very well taken, thank you. Fifth pillar means that you can start this whenever the patient comes. We don't have the evidence. If you ask me that whether in a certain phenotype this is a fifth pillar, I say yes. The concept of 4 pillars means that this drug should be initiated for everybody, whenever they come. Here we have the evidence for phenotype of patients with worsening event within the past 6 months. This is the optimal phenotype for this drug. So yes, the fifth pillar, however, for those, they certain phenotypes. In this context, I would like to allude to the very recent position paper by Heart Failure Association, which actually placed, as you said, in the middle, these four pillars, and said, please remember that also for some other phenotypes, like worsening heart failure patients, there is a fifth, sixth, or seventh pillars. If you take iron deficiency, you have carboxymalate, you have atrophy, you have a fifth pillar in treatment of atrial fibrillation, etc. So to make long story short, yes, fifth pillar at the moment for those with recently decompensated worsening heart failure. In the future, I can't tell you because if Victor is positive, then we have definitely fifth pillar.
Yeah, you have made it very clear this has to be added after making the patient euvolemic, right?
I would say so, yes.
Patient should be
No,
tracked.
yes.
Yeah, and I
Yeah,
think the same thing.
because it's good.
Yeah, same thing we do it for beta blockers also. We have to initiate beta blockers in our failure when patient is made euvolemic after IV diabetes. So I think with this we close this particular presentation. So thank you very much, sir, for your excellent overview and deliberations on this new molecule in the management of heart failure. So definitely this is because this mechanism of action is totally different, because we know that there are 3 to 4 important mechanisms for heart failure. One is renin-angiotensin-aldosterone system, and second is sympathetic overactivity, and third is, of course, the role of sacubitril this thing. Now this guanylyl cyclase activator. So definitely heart failure is a complex syndrome where there are multiple mechanisms. So we need to address all these multiple targets for a better outcome, because the whole objective of treating heart failure is number one is to reduce hospitalization and also to improve the quality of life. Third one is preventing the progression of heart failure. So, yeah. So we'll go ahead with this case presentation, a case scenario of post-worsening heart failure event, and let us look at this presentation.
I know that you are hectically busy clinically. I just want to present one case of a, I would say, ideal for consideration. Having a 72-year-old gentleman with HFrEF diagnosed with ischemic cardiomyopathy a long time ago, with arterial myocardial infarction, diagnosed HFrEF. He was hospitalized last year with 2 years ago actually with ICD, and currently he's back to the hospital following worsening heart failure. He experiences heart failure symptoms and signs of dyspnea, edema, and weight gain, which is obvious. He has got coronary artery disease, type 2 diabetes, dyslipidemia, CKD, as you see here. His blood pressure is 100/75. He is with atrial fib. There are no signs of acute ischemia, ejection fraction not that much different versus, and I would love to hear your comments, how you manage these patients. NT-proBNP in the range of 4,000. EGFR not that low, but still lowish, around 40. At hospital admission, he receives rivaroxaban, sacubitril/valsartan, bisoprolol, furosemide, and atorvastatin. And I would love to hear from you, is this optimal therapy? This is this peri-discharge phase. Would you consider this patient? Would you consider this patient as a patient for optimal therapy? This is, as you see here, the second decompensation. The guidelines are the guidelines. I would like to briefly mention that he is within this recommendation. European Society of Cardiology recommends 2BB. We can discuss why. Americans recommend the same kind of, but I'm very glad that they, for the first time, mentioned worsening heart failure as a period to optimize therapy with the receiver. And finally, Canadians. I don't want to spend your time. That would be my humble consideration, a little bit more furosemide on the follow-up. We can discuss, and I'm very happy to discuss decongestion strategies also in the context of SGLT2 inhibitors. As you see here, he has got drop in blood in antiprotein, which is great. His blood pressure is now in the range of 110, 115 before discharge. So we put him on, please remember, EGFR in the range of 40-ish. Rivaroxaban, sacubitril, valsartan, bisoprolol, furosemide, obviously to be modified, DAPA, and we consider the receiver as an important element of the therapy. I would be more than happy to see what you think.
Yeah, we agree with you, Professor, because this is a case which fits in very well with personal heart failure, and having stabilized the volume status, we have introduced the SGLT2, which is very appropriate, and with that, I think Versiga also comes into picture in this particular case. And this is a typical case, probably, wherein we would introduce Versiga.
But I hope that you agree with me that these cases are so many around that most of patients would qualify for this therapy because only a very, very low EGFR, very low blood pressure below 100, an optimal volume, as you correctly pointed out, statins would not, but most of cases are falling into this criterion where we would consider a receiver. I don't know whether you agree.
Definitely, we agree with this. Because going by the Victoria trial, I think this case fits into that. The cases which were randomized, no doubt about it. But I have one question here. If the blood pressure is borderline between 90 to 100, around 90, what would be your call? Would you still introduce the receiver, or would you want the blood pressure to be beyond 100 to introduce something similar to?
I would myself, although yes, I understand this, but if this is not symptomatic patient who really suffers from episodes of low blood pressure, first of all, I would make sure they are, as you are doing everyday clinical practice, that there are not too much diuretics he or she needs, there are not other therapies which may well be potentially leading to this hypertension, are not only related to cardiovascular therapy, but as you know, several other centrally acting drugs may develop that kind of potential side effects. And then if I am certain that this is not hypotension symptomatic in the range of 95 to 100, I would be happy to start 2.5 and see what is going on. I would not expect further drop and deterioration, although we do not have evidence. With time, I'm sure that with time, particularly from your country, we will learn more in our clinical practice, because soon you tell us, and this is I'm sure your advantage, because with time you would initiate the therapy in these borderline patients for whom it's
yeah, actually, in patients with chronic congestive cardiac failure, this blood pressure, I mean, whatever reference we are taking, 100 millimeters of systolic blood pressure, it has to be interpreted along with other corroborative things. If extremities are warm, if the extremities are warm, many times you are surprised. If you check their blood pressure, they are stable, they are ambulatory, their blood pressure is 80 by 60. And in fact, we don't want to write on the prescription, I mean, follow-up record 80 by 60. We blindly write 100 by 70 or maybe 90/6 many times. You make them stand. See, that's what we have seen. Even if systolic blood pressure is maybe 80/60 or 90/60, heart failure patients I'm talking about, you make them stand, their systolic blood pressure goes to 100, 110. So that is how clinically we need to evaluate. So in fact, many of the doctors are very reluctant to write those blood pressures, say 80/60. They are absolutely stable, urine output is fine, and extremities are warm. So if that is the scenario, despite blood pressure being 95 or 95 to 100, still we can use these drugs.
And entirely agree with you.
And it is true, many in the routine practice on the follow-up sheet, they are afraid to write 80/60, they write 100/70.
Professor, I understand that you are also part of the Socrates trial. Any insights from those trials, both preserved ejection fraction and reduced ejection fraction? Any differences with respect to the outcomes?
The Socrates program, as you correctly pointed out, comprised both arms, preserved and reduced, and it was across the whole spectrum of ejection fraction. In the Socrates program, which was actually dose-finding study in HFrEF, we were pretty sure that we should go for that much bigger trial with mortality and morbidity. In the Socrates Preserve, we had a very clear signal that it may very well work in the context of symptoms. And then we did vitality or vitality program when there was a neutral data. So whatsoever, we do not have a confirmation that in patients with heart failure and preserved ejection fraction, the drug for this pathway, although we feel immediately that perhaps even this patient will have that could be benefit more because this pathway may well be particularly important, or impairment of this pathway may well be particularly important in some patients with HFpEF. We don't have the evidence, so I'm sorry to tell you we don't have the evidence in HFpEF.
Any questions of that? I thank you profusely, Professor Rao. And it was a wonderful program. Thank you for inviting us to this. Thank you.
Pleasure. Thank you. And once again, apologies for not being able to travel. I would love to travel maybe next few weeks, months. Again, we will start and we'll be debating about something else. I would love to share and to talk to you in person. Always better, but sorry for today. Take care, guys. Bye.
Thank you. You take care.
Thank you everyone. Thanks a lot for joining and taking part in the discussion today. I would like to thank Dr. C. Manjal sir, Dr. V. Sri and Dr. Srinivas also for joining us and making us go through this wonderful data and give you insights. And looking forward and hopeful for having such wonderful discussions in the future as well. I have here Mr. Rajesh Chinana, who is our marketing head. Please.
Yeah, we have. Pleasant.
you so much. Just more than 10%. You look very